Hello, everybody, and welcome to the Society of Actuaries Professional Development Edge podcast. I'm John Forster. I'm excited to be here today, and we got two great guests. First off, we got Dave Dillon. Dave is our SOA president. Dave is also a VP and principal at Lewis and Ellis and one of the top healthcare actuaries in the country. We also got none other than Mark Cuban. Mark's known for a bunch of things, but the reason we got him on today is we're really interested in his role at Mark Cuban's Cost Plus Drugs. How you two guys doing today?
I'm great.
Doing great. Thanks
Excellent.
for having me.
Yeah. Glad you both could join us. We've been looking to put this together for a while, so glad it's come together. So we're going to get into all the Cost Plus drug and healthcare information in a bit. I first wanted to start out talking to you, Mark, about the entrepreneurial business side of things. I know we listen to some of your other podcasts out there. You talk a lot about luck and luck's involvement, but there's also two dynamics. There's luck, and then there's the execution, work ethic, perseverance. How have those two things blended in your own background, in your own career?
I mean, in terms of hard work, I don't work any harder than you guys. We all bust our ass as much as we can and hope things work out for the best. But sometimes luck plays a role. I was a tech geek, and right around the time I had sold one company, the internet started to happen, and the internet stock market started to take off. So when I started the first streaming company, AudioNet, and the internet stock market happened to blow up at the same time, right? It was perfect alignment, and that's luck. If I would have been born 2 years later or earlier, who knows what would have happened? We wouldn't be having this conversation. So luck always plays a role. Wayne Gretzky talks about the fact that he came up at the exact right time when they changed the rules to allow for more scoring. If he'd come in a couple years early, we might not know his name. So, you can't ever deny that luck plays a role when you get to, this level of financial success, because I'm not here to say I work harder than anybody else.
Mark, it's funny so I've been in the healthcare reform business 15, 20 years. And I am not afraid to say my first job that I bid on to do healthcare reform work, I was the only person to submit a bid. So that's luck right there, right?
But did you get it, right? Because not everybody would get it. Yeah.
Correct. So I got it. And, if other people had bid on it, maybe I wouldn't have got it. But there was definitely a lot of luck there. And then, that has fed into more and more work and things like that. So,
because then that's the hard part, right? Because you got to do a good job.
You do.
Otherwise, you're kicked to the curb.
Yeah. And so one thing I've learned, so I've been a healthcare actuary for 30 years. And one of the things that, that has definitely jumped out at me is, and this isn't just a healthcare reform topic you brought up, but through all of your stuff, it is about transparency, right? A lot of jobs, people get really, they hold tight on the stuff, and that's not always great for certain fields. So can you talk a little bit about kind of the reason for your position on transparency and why it is so central to your businesses?
Well, let me tell you how Cost Plus got started. I got a cold email from my partner, co-founder, Dr. Alex Loshmayansky. He wanted to do a compounding pharmacy that made generic drugs, generic injectables that were in short supply. Believe it or not, there's still pediatric cancer drugs and commonly used drugs that go on shortage lists. And I thought that's a great idea. That's needed, but it's not big enough. And as it turns out, this was right around the time that the pharma bro was going to jail. And I was like, how did he get away with jacking up the price of this generic drug, Daraprim, so much? And, as I dug into it, it was very obvious that there was no transparency in all of healthcare, starting with the pharmacy side of it. When you go to the doctor and you get a prescription, they don't talk about affordability. They don't talk about the price. They don't talk about how much is your deductible and how much is out of pocket. They just say, what pharmacy do you use? And you've got to figure out the rest. And to me, that was an opportunity. So I started digging in further, and there was no place where you could go and see what it cost to manufacture, what the markup is, and what the final sales price was that charged the same price to everybody. There are random places you can get a price at any given point in time, but we wanted the place to be where when you go to costplusdrugs.com and put in the name of the medication, if it's one of the thousands we carry, you will see exactly what we pay. you will see that we have a 15% markup, and we chose 15% only because I thought it was fair. And if it's mail order, you pay $5 for the shipping and handling. That's it. And in doing so, we underpriced everybody, but more importantly, people trust us. And to answer your question, Dave, transparency is important because without transparency, there's a lack of trust. And that's the problem we see in all of healthcare on the financial side, because there is zero transparency 99% of the time. And so people don't trust it. They don't know why they're paying, what they're paying. They don't know how they'll get billed, when they'll get billed, if they'll get billed. They don't know if they'll get clawbacks. And that applies not only to patients, but to physicians and pharmacists and practices and clinics. Everybody struggles because of lack of transparency.
Yeah, definitely a great story and a great concept there. And I love the way you dove in and saw an opportunity and took it. We're going to get a little more deeper into the RX side, but I want to pivot on that more of the story of finding an area and getting into it that's outside of the box. How should actuaries and other professionals be thinking about that to try to pivot into a different
well, it's hard for most people to understand actuarial services and what that even means. But I think the opportunity is now, because when there's something going on that is timely and very public, and actuarial the actuarial values of things are important, now's the time to speak up. And what's going on with the ACA and responses to the ACA is critical. I mean, this is every conversation should be built on the actuarial value of all the options that are being presented. But we don't hear that at all, and people don't dig in. And so when there's change, there's opportunity. And I think with actuarial services, people don't truly understand what's going on when it comes to valuing different options in healthcare. There's nobody standing up for the actuarial side of it to explain to people, look, here's the actual actuarial value of an HSA account the way it is today. Here's the one that Ron Wyden wants to propose with Bill Cassidy, where it's 1,000 or 1,500. This is the expected actuarial value. Because if that actuarial value is 15%, right, that means a lot. And so I think that's the missing link for the actuarial industry in healthcare right now. When there's a lot of discussion, you guys still wait for somebody to come to you. And that's one of the reasons why I wanted to do this podcast, because there's nothing more timely or important in the conversation about the cost of healthcare than what you guys contribute to that conversation.
Well, I appreciate that, because it is a very challenging analysis with a lot of moving parts, and dealing with the politicians who don't always necessarily understand if they push the balloon here, what's going to happen on the other side.
Right.
And so I do want to leverage something you said. You touched on this a little bit, but healthcare, obviously there are lots of middlemen and cost shifts, right? There's only so much payment in this system, and so you got to make up for it elsewhere. So it's a very complicated process. How do you see that evolving? So you've started a company now that's a little more on the wellness side, and we'll circle back to some of the drug stuff too, because I'm very interested in that as well. But what do you see? Like, how can we simplify the system?
You take out the middleman, and you look at common sense approaches to the things that they've done that need to be changed. Basic stuff like using net pricing. Basic stuff like allowing somebody who makes a cash price because that MRI was dramatically cheaper, and allowing them to apply it to their deductible, as opposed to whether it's in network or out of network. Basic stuff, the same thing applying to drugs as well. Basic stuff like if there's a doctor that a direct primary care doctor that I can pay $100 a month, allowing me to do that as part of the program I'm part of, knowing that it probably ends up saving a lot of money. And typically, the middlemen are the PBMs that introduce rebates and do all these other things, and the companies that own them, the biggest insurance companies who game the entire system, the biggest insurance company has 2,600 subsidiaries. They have intercompany transfers of $161 billion. That's 0.53% of American GDP. There is no good reason for them to have been allowed to get that big. And so we can start with the interim things like allowing, as I said, cash price where a patient determines, or even an employer determines there's a better option here that's less expensive. Let me apply it to my deductible using net pricing on pharmacy. But most importantly, don't let them continue to make acquisitions and hopefully, and I'm a hardcore capitalist. I just happen to be more of a compassionate type of capitalist, but you've got to break them up. You can't let them game the system with these intercompany transfers that ends up costing patients and employers a ton of money because it's not transparent.
I know you started going down the road of the high deductible plans and an HSA. The actuarial side on why the premium gets lower on those high deductible plans is because there's that cost shifting, and the member has some skin in the game with choosing their hospitals and doctors and prescription services like Cost Plus. Like, what's your take on the high deductible plans?
That's a great question. It really depends on what else comes along, right? Because it's one thing, because people say, okay, what's the least premium, the smallest premium I can get, right? We want to pay the least, but then your deductible obviously is inverse, so you have a bigger deductible, but most people can't afford a $10,000 deductible. The typical ACA Silver plan now has a deductible of give or take $5,000 for a family of four, and the max out of pocket was $9,400, and it's going up even more, right? Multiply that times the size of the family, and there's just no way most people can afford that, and that actually benefits the carrier. Because if you can't afford your deductible, you're not getting the care, which means there's no out of pocket for the carrier. But it also puts the provider, particularly hospitals, in a bad situation because they have somebody come to the hospital was in a car wreck and it's going to be, expensive. Well, if they can't afford their deductible, what do? You just, stabilize them through the emergency room and write it off? No. What ends up happening is they put together financing plans for that patient so they spend enough to get to the deductible, but now you've turned that hospital into a subprime lender because they're lending all this money to patients to help them reach their deductible. And when they can't pay back that money, now you have all this medical debt that we always read about that's in billions and billions of dollars, hundreds of billions of dollars. And hospitals then, some of them, not all of them, but some of them tend to go after them and put people in bankruptcy. So the question is, knowing that there's this vicious cycle, what can we do to help patients with their deductibles? I've always been a proponent, don't give them money in the HSA accounts, right? Because it doesn't even cover their deductible, right? They might as well just, pay the 20% fine and go out and party, or use it for their rent because it doesn't solve the problem. When somebody can't afford their deductible, then the whole thing falls apart. The carrier benefits because they're not using the care. And if they have to use the care, then the hospital in turn has to loan them the money effectively till they get to their deductible, which turns them into a subprime lender. What I've always thought would work is if the taxpayer guaranteed, rather than giving them all the HSA money, guaranteed deductibles, so that as long as the amount being paid to the hospital is Medicare rates or 120% of Medicare, whatever that reference price we set up as, we'll guarantee it. And then we'll allow the patient to repay it, but we'll means test that repayment. So that if, let's just say you're at 250% of the federal poverty level, you may pay back 2% of your income. And then at some point, 10 years later, whatever is down the line, we'll write that off for you as long as you've continued to make your payments. I haven't done the math. I don't have all the data to be able to do the math to say whether or not, the actual actuarial value in terms of actual care provided is better. But my guess is if everybody can use all of their deductible and the payment is guaranteed to the provider, that's about as close to 100% of actuarial value as you can get. And in terms of the taxpayer's perspective, as long as, what the non-payment to the taxpayer, the default rate on the taxpayer ends up costing less than what you would have paid just in money given to HSAs, the taxpayer is ahead of the game. We're a healthier nation. Things are more transparent. Everybody is able to get the care they need when they need it, and we're better off. So that's kind of, maybe you're sorry you asked, John, but that's kind of the way I look at it.
Well, Mark, I'm curious, and you touched on this a little bit, and you may have provided a little bit of an answer. But in the U.S., the healthcare system is somewhat of a Frankenstein, right? It's
Yep.
been built over several models. A lot of people don't realize, we do have a little bit of a single payer, right, with Medicare, and then we have the low
Medicaid,
income
yep.
system, and
Yep.
we have the employer, and all of that. So healthcare is just huge. And do you see an easy opportunity to start unwinding it a little bit, right? So like I always get the question, why don't we go to single payer like other countries or things like that? And to me, it's a little bit of, moving a boat at a slow speed. But I was just curious if you see any opportunities for
It's a great question.
doing that.
First, you're the first person to nail it. Medicaid, ACA with CSRs, the cost sharing reductions, and certain Medicare programs. That's as single payer as you can get. And we have over 100 million people within those programs. So it's not like we don't have it, but the entire structure that we have now, when you look at other countries that got into single payer or universal health care, almost all but one or two did it in the 80s or earlier. Right? Some were over 100 years ago, 150 years ago, when we didn't have as much technology, we didn't have the infrastructure built up. People went to the doctor, and if they couldn't pay them, they gave them a chicken, right? And so it was a lot easier to switch to that culturally than it would be right now. And plus, you have so many providers, particularly large hospital systems, who have spent so much money on branding so that their costs are way out of whack they wouldn't be able to work within a single payer system without basically shutting down or opting out of the single payer system. And that would create its own set of havoc. And third, I've read all the single payer Medicare for all proposals from Representative Jayapal and Bernie Sanders. And the first thing it says, at the discretion of the Secretary of Health and Human Services, A, B, and C will happen. Depending on the administration, that could be good or bad, and you don't want a system that's going to, zig way left or zig way right. So for us as a country, our culture, I think, makes it very difficult. That said, healthcare, the economic side of healthcare is very easy. It's how much does it cost, who pays for it, and if they can't afford it, who covers the debt, right? Who's responsible for what the patient can't pay? And we need the transparency, because with transparency, then you can start to look what the aggregate cost of claims are for any given group, right? So if the state of Pennsylvania decided they wanted to offer single payer for the entire state, every resident of the state, then they can say, here's our claims history, here's what we project, here's the cost of care as we see it. And if we went to straight Medicare payments, this is what it would cost us. We can go survey all the providers in the state to see who finds that acceptable, and is that a big enough network? And then we make a choice. But you can only do that and make the Pennsylvania taxpayers the payer of last resort if there's enough transparency with costs and claims. Because if you look at Canada, it was Saskatchewan, maybe, Winnipeg, Manitoba, I forget which one. It was one province in Canada in 1947 that decided we're paying all the healthcare for our province. They negotiated everything, then another province, and it took 20 years or so for everybody to get it. There's nothing that would prevent a state, a city, a county from doing the exact same thing here to set a precedent. But in order for that to happen, you have to know what something costs and who's going to participate in providing that care or providing those medications. How is it going to be paid for? What percent is coming in premiums from the beneficiary, and hopefully not doing taxes, but what percent might employers pay as a percent of wages that can contribute to pay for the whole thing. And if you can make the math work, you can go to single payer within that group, right? And then you guys will do the actuarial value, and people will determine if it's worth the money or not. So if Pennsylvania was able to put together a program that had 94% actuarial value, and the employers paid, like they do in the UK, 15% of wages up to 75K, and the employee paid, depending on their earnings, anywhere from 2 to 8%, and the math worked, great, because we would disengage from employers. We'd be able to get all the medication you needed, et cetera, et cetera, et cetera. But you got to be able to do the math and willing to go through that process. We don't have that will in this country. That's just the unfortunate reality. But at Cost Plus, we're trying to do our part, where we're saying, here's the cost of medications. That's the same price to everybody. Here's our markup. If our cost goes down because our volumes go up, your cost goes down. And so that's what we're trying to do as a first step. And we're also trying to do it on the medical side now as well. We've created something called costpluswellness.com, where we're doing direct contracting for my companies with providers around Texas and around the country. And all those contracts are all cash pay contracts. There are no pre-authorizations. It's a reference-based price of Medicare, depending on the provider. And me as the employer commits, I'll pay cash the minute it happens, right? The minute the care is provided. And just that cash flow improvement and transparency to the provider, we've gotten 9,000 doctors signed up in less than a year. But the more important part is, on Cost Plus Wellness, we're publishing all of those contracts. So if the SOA for their employees wanted a sample contract to take to employers, where you guys are, or make it available to all, I don't even know, all your affiliates, they could just take those contracts and start from there. They're not perfectly negotiated, but it's a good starting point. And so when you pull all these pieces together, unique things can happen, and that's what we're trying to do.
Sounds good, Mark. Now let's talk about AI. AI is coming, technology is coming. How do you see that impacting both?
Well, I'll ask you guys, right? As actuaries, does it work? Like, if you plug in questions, into ChatGPT, or are there actuarial specific AI programs? I'm sure there are that are being sold. Like, what do you guys think? Because you guys have the hard job. I can talk about the easy stuff. You guys do the complicated
good
stuff.
question. That's actually a lot of my job right now, is making sure that actuaries are kind of embraced with harnessing the power of AI. And you always need that human in the loop. We're calling it an actuary in the loop, right? I think that's what we're finding. It definitely is extremely helpful in helping us with modeling, coding, with finding information, but it makes mistakes, right? And that's what we're finding, is that, if you're able to work that into your process, not let AI be the process, you're able to work that into your process. It definitely is helping with a lot of actuaries are definitely using it to help out with a lot of their systems.
Do you guys use agents at all? So, like, if you did an actuarial evaluation for my companies, to say, okay, we looked at your plans, here's the actuarial value for your plans. Do you guys use agentic AI to create agents where I could feed you all of our claims and payments, and then you guys could then compare them to your models to see and just fine tune them continuously?
Yeah, I would say we're getting there. I think we'd like to get to that spot where the old phrase "trust but verify." I don't even know if we're quite at the trust yet.
No, we're not yet. Yeah,
but we're definitely at the point where we could do that, and it would definitely help the iterative process, right, and help speed things up and stuff like that.
Because tell me if I'm wrong, the hardest part of your business is the grunt work, right? All the detailed work where you have to take all the data sources, and you hope that you get composite data sources as opposed to individual claims that you have to aggregate. But either way, you have to make that work. And I would think that, and again, correct me if I'm wrong, I would think that agentic AI, where you could just go into my systems and pull the data that you need with all the security required and all that, so that you can make sure that you get the right data. Because I can't imagine the number of times you've been in meetings where you said, well, this is the data you gave us. Our numbers are right, but garbage in, garbage out.
Yeah, and the SOA, Dave works for Lewis and Ellis Consultant, but the SOA, we reach out to a lot of different members, and the data cleanup is a key use case that actuaries are starting to use it for, finding outliers in data, and then also creating synthetic data for our modeling that's based on
Right, which is really
parameters.
cool.
So
Yeah. Are you guys using it to source data? In other words, you use AI to go through and find the data you need from whoever it is you're doing work for.
I haven't done a whole lot of that. I've got a feeling that there are others. We're still, I would say, not using it for that purpose. I'd say we're kind of just getting that data dump, kind of what you were alluding to, and then we're
then you scrub the data.
Ourselves.
Then you scrub that data.
We scrub it, and then we may use the AI to help us, analyze that. At this point, as I said, I think where we end up is going to be way different than we are now, and I do think that will ultimately be used.
Do you guys work mostly with what kind of customers do you typically work with?
So the Society of Actuaries broadly. So we it's an organization for not just health actuaries. All right. But I am a health actuary, and as a consultant, a lot of my work is through the regulatory. I do a lot of regulatory work. So I work with a lot of state insurance departments. And, a lot of the regulatory bodies, have a lot of resource issues. So, we're having the conversations like the AI side, where can we use AI to help with lack of resources and things like that. From kind of my non-regulatory work, I'll work with insurance companies primarily. And again, it's just to help with the data analysis. And, like the very typical actuarial problem is, like you mentioned, the AVs. You change a policy, what's going to happen, right? And so we're looking into how that can help, the AI can help us with those kind of analysis.
Right, because it should be consistent, right? If all the data is what it is, you change one variable, then everything should flow accordingly once you get those models built. Yeah, all this is I ask these questions because it's fascinating to me, because you guys really are where the rubber meets the road in all of healthcare, because you are the only way for anybody to understand how things should play out, because so few people are data driven in this industry, other than the insurance carriers and PBMs, because there's such an information asymmetry between employers, employees, right? Anybody else, doctors, they don't have access to the information that the PBMs and the carriers have. And so you guys, are the only ones that I see that, try to keep, that can help the rest of us keep them honest.
The SOA has a lot of different employers and actuaries that we support. So we're trying to enable them with the tools available to do their
And I'll tell you this, if you guys, like for these ACA proposals that are being put out, alternative proposals that are being put out with the HSAs, if you guys came up with any type of actuarial values associated with them and got them to me, I would get them everywhere and give you guys the credit and hopefully educate people on it. Because to me, it could be a disaster waiting to happen. If these HSAs have an AV of 20% or 40%, and they're walking away from programs, the worst of are the the 70s or whatever they are for the bronze, that's a disaster, and it's a disaster for taxpayers too, because we're giving our money away to do things that we aren't what we expect them to do with the money.
Yeah, one of the key words you mentioned is the education. So part of John's group is to help educate actuaries on like the AI side. And as you said, it can be a challenge for us because you mentioned earlier, we've historically been the number crunchers, and now the AI is doing quite a bit of that. And John's group, we're trying to help educate people. How are we still ourselves educated enough to communicate what is going on?
Well, that's where I'll help you. I'll help you there. If you guys do the number crunching on the HSA options and we talk from there, I'll get it out there and help you educate. because there's no better time to educate people than when there's a crisis, right? Or when there's change. Change is always opportunity. And so you'll look back and say, what was how did we get lucky? Well, the first time was when I was the only bidder. The second time was when everybody wanted to change the ACA and nobody understood actuarial values. And we stood up and explained and educated people, and people started getting us in the mix on the healthcare side, as you should be, because every determination, whether you're an employer or governor or politician, that AV value is as important as any number in healthcare right now, the economic side of healthcare, and nobody knows what the hell it even is.
Thanks a lot, Mark. I think you bring a lot of good insights to the table. Dave, thanks a lot for being on this podcast. We appreciate it from the Society of Actuaries, and catch you all on another Professional Development Edge Plus podcast down the road. Thanks, everybody.
Thank you, John.
Thanks, John. Thanks, Dave.
The views and opinions expressed in Society of Actuaries podcasts are those of the speakers or authors and do not necessarily reflect the views of their employers or the SOA. The opinions expressed should not be construed as legal or professional advice and are provided for educational purposes only. Please see the terms of use on SOA.org for more information.